introduction, and with this I would like to hand over to Dr. Ian Banks, who is a very experienced primary care specialist on one hand, so he has the physician's hat, but on the other hand, especially also patient advocate from own experience and also from the patient advocate experience, very, very knowledgeable in the area of patient involvement, engagement with practical experiences, and it will be very interesting to hear your point of view when we talk about the benefit and risk assessment and how to improve that and facilitate that when we discuss nanomedicine's development. Thank you very much, Ian.
And Ingrid's actually...
Sorry, no, you need that one.
Ingrid's actually covered a good chunk of what I was going to talk about. So I've rewritten it in my head now and cut out some of them. So you'll be glad to hear I'll be giving you a condensed version of this. I'm not actually a primary care expert. I am a trauma doctor, or was a trauma doctor in Belfast. And worked in accident and emergency for 30 years. Through all the troubles of Belfast, so I know a few things about, I knew things about way things go badly, but nonetheless, I've been involved in primary care with the European Cancer Organization to try and get the primary care workers involved in that. But what I've come to speak about today, as Ingrid has outlined, is the value of patient input. And you might think that's a bit strange coming from somebody who works did work in a trauma department. Most people who are in trauma departments don't say very much. You know, and most times you make decisions with people who have been very badly traumatized without asking them, would you like me to do this? You just do it at the time, not least because they're going to die if you don't. So it's a bit strange, but I've come at this from a different direction, and I'm now absolutely convinced that listening to what patients say is not only a good idea, it's absolutely essential. And that is also true, particularly true when it comes to looking after them or their relatives, but it's also true for research and for clinical trials. And as we've already seen the value of this, so I'm going to skip some of that. But first of all, does anybody recognize what's going on here? Does anybody recognize this picture? Anybody see that? My son's an astronomer, my eldest son's an astronomer in Manchester in England. And he sends me these pictures. I said, Dad, weave this into your presentation. But does anybody recognize it? It's Venus traveling across the sun, look. And Venus does this every few hundred years or whatever, okay? So life expectancy in Europe is going up. So if you missed it, don't worry, it'll come round again, and you might see it again because of life expectancy improving. But this thing has been going on for countless millennia, where Venus has moved across the surface of the sun. And so Stone Age man would look up at this and go, ugh, you see, and take no notice, because it didn't do anything. Nothing happened because Venus moved across the surface of the sun. And so therefore nobody took any notice, and nothing actually happened about it. So it happened millennia after millennia, this thing doing nothing. And then in the 1700s, they sent a sailing ship down from Greenwich near London, down to the southern hemisphere with a telescope and a clock. And they had exactly the same telescope and exactly the same clock in Greenwich. And when the sailing ship got into the southern hemisphere, they waited for this to happen. They knew it was going to happen, and they waited for it. And they timed it. They timed the onset of this movement across the sun by Venus. And when they brought the clock back home and they looked at the two clocks in Greenwich, they were different. And the reason why they were different, of course, is because if you measure the movement of a body like this from the southern hemisphere, because of the tilt, you get a different timing. Now that enabled scientists then in the 1700s to triangulate, and they could work out the distance from Earth to Venus, from Earth to the Sun, from Earth to all the known planets then of the solar system. That was in the 1700s. And the reason, particularly to the students who are here, the reason why that is so important is because that was the birth of modern astronomy. Because somebody noticed a difference and critically acted upon that difference. And that is the basis, not just of modern astronomy, but of modern medicine, where you look for a difference, and on the basis of that difference, then you make a decision about what to do. And without that critical assessment, and without that listening and watching for a difference, then things start to fall apart. So if you run on assumption, if you just presume all the time, and this is what I'm constantly teaching with medical students in accident departments, is if you run on presumption, eventually you will make a mistake. If you look for the difference constantly, you will be safe and you will keep your patients safe. And this has been a maxim which I have kept for many, many years, and it's kept me safe anyway, and kept patients safe, touch wood. But this was from listening and noticing a difference, and that's what I want to try and get through to you today. That, if you like, is the overall message of the value of noticing a difference and then acting upon it. So I'm just going to skip some of these now, if I can just get through this. You've seen all these, so I'm not going to stick on this. But this is what it all adds up to for me. Okay, now I've been invited to come here from the European Men's Health Forum. It's a misnomer, really. You can't separate men's health and women's health. The two are often inextricably linked, and if you change the health of one sex, you will invariably affect the health of the other, and their children, by the way. We know this. But I've come from the European Men's Health Forum, and so I'm going to talk about this from that direction, about the importance of designing trials and designing research where it becomes relevant to the people who you're going to actually use these medicines in. Now, you've already heard about very briefly there, about the adverse effects reporting and adverse reactions reporting and so on, events. Men, you'll be surprised to maybe not be surprised to know that men very rarely report adverse events from medicines, or for that matter, devices, even worse with devices. And yet, we test most medicines and most devices in men. It's a real paradox. And we have the absolute absurdity that most medicines are actually taken by older women. So you have a testing system based upon young, fit, healthy men to be used in older, chronically ill women. A crazy situation of research, and one which you would never duplicate if you were in the car industry, for instance. You would never, ever use that kind of a system to do this. So here we have the paradox, and here we have the problem. We also have this. This is the pyramid projected, for population pyramid for the UK in 2060. Now, I accept, given the absurdity of the vote which took place in the referendum very recently, this may change. I mean, at least Scotland will not be represented in there. Scotland is a country near England, by the way, for those of you who aren't unaware. I've just lost the Scottish vote. Now, that will probably change. Northern Ireland, where I practice in Belfast, that will probably disappear off there as well. So this could change. But actually, if you look across all of Europe, that is probably true, that pyramid will actually happen. So you will have a much older age group, depending upon a younger age group, for things like pensions. And this is the work and retirement. You're wondering, why is this guy talking about this? You'll see in a moment how critical this is to the mind of people who you are trying to think about the ethics of clinical trials and research and how it should be directed and what we should be looking for. This is a retirement age right across Europe, and in every country in Europe, just about every country in Europe, they're lifting the retirement age. You will have to work longer in your workplace before you retire. Now, some people say that's terrible, you know. Well, actually what we've found is that work is actually critical to an awful lot of good health in people, both women and men. And in fact, we know that, and I'm going to show you this in a second, we know that worklessness is the equivalent of smoking something like 10 packs of cigarettes a day. That's being out of work. That's what it does to your health, just not being in work kind of thing. So, so this is quite critical. But we've got the anomaly here as well. We've got the paradox. They wish to lift the retirement age. And yet most of the medicines, if you like, are not there, they're not designed to help this sociological change, if you like, in our workforce. Now, is this important to people? Well, let's look at cancer. That's where I specialize at the moment. I sit on the board of ECHO. It's the European Cancer Organization, a huge organization for cancer with all the specialists all in there. And this is the kind of work that they're looking at. Approximately 2/3 of cancer patients either continue working or return to work after their diagnosis of cancer. That's incredible. You think about 2/3 of people actually, they've been told they've got cancer and they carry on working. that, if you think about people just giving up, that's not what we find. People actually got to carry on, okay? So that's the number one. And think about this in terms of research, okay? Clinical trials, okay? After only 1 month away from work, however, the chance of a successful return has fallen to only 90%, and in 6 months, the absence falls below 50%. In other words, the longer you stay off work, the less chance you've got of actually going back to work. That's a critical statement for people who see work as central to who they are in the sense. And worklessness, as I've said, carries the same health risk as smoking 10 boxes of cigarettes a day. Amazing. I didn't know that. That was the WHO come out with that. So here's return and remaining at work. Here's the economic implications. Ill health retirement may cost a business 3 times the salary cost in addition to any pension payment. Most employers don't realise that, just how expensive it is to have early retirement. Ill health amongst the working age population in the UK alone costs the equivalent of running a second health service. In other words, simply having people ill in their work age and looking after them is the equivalent of having another health service, another NHS, a whole service in terms of cost. And approximately 42% of cancer patients are diagnosed at working age between 15 and 64 years. 42% of cancer patients are working when they're diagnosed. And that's going to rise because cancer is age-related. Many of the cancers are age-related. And then finally, the social cost for the European Union, of which the United Kingdom is no longer a member, was estimated in 2009 at around 126 billion euros. 60% of the economic burden of the cancer was in non-healthcare areas. In other words, it wasn't the actual cost in terms of the delivery of the medicines or whatever. It was all the other things surrounding it, which is what cost the money. Think of those numbers for a moment, and then think about what Ingrid said about the wastage in research that actually takes place. And you put those together, you can see how critical it is to actually listen to people who you're going to give the medicines to and what they want them for and how you expect them to work. That's so critical if you're going to have your research as valuable to society and to the individuals. That's how important these numbers are. And there's people at the end of these numbers. I know it's a cliche, but there are people at the other end of these numbers. And this is one of my next to final slides. And this is the impact this has on men now. We're talking about men. This is suicide rates. We talked all about the economy and so on. Okay, well, let's just imagine that we're all now human beings worrying and empathizing with our fellow human beings, okay? For me, suicide is one of the most horrendous things that can happen to a family and to a workplace and to a school and to wherever. Because it's like a little pebble that drops into a pool. The misery from suicide doesn't just stop with the individual. It spreads out like ripples in a pond and affects more and more and more people as it spreads out. It is a terrible part of what happens with human beings. And here is the starkness of the reality of suicide in men. Because this group here, right, you see the big rise in suicide here. This is in the UK now, okay? But actually this is mimicked across Europe. Look at the rise in suicide here in the working age group. Now, you have to ask yourself, what is going on here? Well, there's something about the male psychology, because if you look at the female side of that doesn't happen. It stays flat. It doesn't happen when it looks to the position of losing jobs. And we've had lots of discussions about this, but one of the things we do know is that work is central to the male psyche in terms of what we are. I'm a retired doctor now, and you've heard me at least once say my work as a doctor. I don't do it anymore. I simply teach it. When you get to my age, you don't do it anymore. You just teach it. And most of that, of course, you're trying to do it from memory. But that's me. I'm saying to you, that's what I am. And particularly to men, that is the identification. And when men lose their jobs, the suicide rate goes straight up. And they lose their jobs for many, many reasons. But ill health is one of them. And because the workers' rights have declined so badly across Europe, we get this impression they've gone up so wonderfully. They haven't. They've been eroded so many places in terms of short-term contracts and so on, ill health. Well, when they lose their jobs, suicide goes straight up. When they're made redundant, suicide goes straight up. We don't see that in women. Women are much more holistic in the way they approach something like this. If two men meet each other, what's the first question they ask each other? It's, what do you do for a living? I've seen it so many times. They shake hands and they say, what do you do for a living? Total stranger. Women don't do that. Women talk much more holistically. They'll talk about the European Union. It was the first thing when we met. The first thing we talked about was Brexit. We didn't say, what do you do? You know, kind of thing. But it's built in. And lose that identity, and men actually then lose, unfortunately, the sense of the will to live. So this is important. Now, when I was in the middle of working in this horrible environment that was in Northern Ireland at the time, I suddenly went deaf. I mean, imagine, it's bad enough having, doctors generally working too many hours, but when you've got a deaf doctor, that really, you're going to start to get worried, So, and a little bit after that, then I went blind. I mean, seriously, I went absolutely blind. And so I had to have 4 corneal grafts where they take the front of your eye out and stick somebody else's in. I've had that done 4 times. And they drilled a hole in my head and stuck this machine in so that I could keep working. Society invested in me by putting this machine in, giving me rejection drugs and so on, so I could keep these lenses and all these things. Invested in me as an older man so I could carry on doing the job I'm doing. All of that research which had gone into developing this machine and developing the transplant procedures and all the drugs that are involved in it enabled me to carry on working at a time in Belfast when that's what we really needed. I mean, we really didn't need deaf, blind doctors. If you saw me coming towards you with a knife, run. Run. You don't want deaf, blind doctors, believe me. So my point about this is that unless we actually can get the European Union to truly invest through younger people, through the pharma industry and devices industry, to invest in people and health, then actually raising the retirement age is a waste of time. Because all you'll do is produce sicker people at work who will then leave work and then claim benefit. There is not only a very strong economic reason for looking after people and investing in health through the kind of miracles that we produce in nanomedicine and so on, but there is also a very good humanitarian reason for doing so. This is the view from where I live in Northern Ireland, and this is across to Belfast. Belfast is over here, and now this was taken a long time ago, and you can just see the Titanic pulling out here on its way. It was okay when it left us, is what we say in Belfast. There's the Titanic pulling out. So, and this, do you recognize this thing here? Do you see this? It's a whirlwind, right? How many of you have ever seen a whirlwind? Okay? Well, I can tell you, in Northern Ireland, we don't see whirlwinds very often. It's not something you look out the window and go, oh, another whirlwind. Oh, God, there we are, Here's a whirlwind here. And this thing came through Northern Ireland, and I live in a little farm, and it ripped the top of our chicken hutch. And we were eating scrambled eggs, and in fact scrambled chickens actually, for quite some time after this thing went through. It didn't kill anybody, but it made an awful mess. Now I put it to you, we see some really strange and weird, really weird, strange things in Northern Ireland. We call them politicians, but we don't see whirlwinds, okay? And I put it to you that we have sown a whirlwind here. If we do not invest in health in the European Union, and if we don't listen to what patients want and need from their medicines, not just what goes wrong, but what does it enable them to do? And in this case, I've used work as a good example, but I could give you any number of examples, okay? But unless we listen to what patients want and need, and unless we listen to them as we go through the research program of what works and what doesn't work, and what entices people to take part in clinical trials, unless we listen to them, then we will reap this whirlwind. We will spend countless fortunes on research which have no value because it's not applicable to the daily lives of the human beings that you're supposed to be giving these medicines to. And unfortunately, the history of medicine is littered with these kind of things, where the medicines did not fit the person, where the device did not fit the person. It was a perfectly good medicine. It was a perfectly good device, but it did not fit the job which that individual wanted it to do within the society and the environment in which they live. So everything that Ingrid has said is absolutely central to the work here. And I'm sure that's part of the discussion that we'll have is, so okay, that's the statement. And the next question is, so how do you involve patients when it comes to listening to them, when it comes to clinical trials and to research? And that's what I hope the panel discussion will do. Thank you very much.